Hey team, welcome back to part 2 of our conversation on reach, grasp, manipulate, orthopedic concerns. Now we're going to talk about ergonomics and how we start to fix things. So when we're talking about how we fix ergonomics, first we can start with the environment itself. You might already know some of this, or you might have done some of this in undergrad, or you might just know it from life, but essentially you want everything at the proper height and within proper reach, because it keeps your joints in a neutral position and it promotes a neutral posture that prevents all of those issues with slouching and things like that keep you from having that slow, lifelong decline into eventual, honestly, neurologic impairment. You also want to make sure that there's good clearance around wherever you're working so that you can have safe movement. Adequate lighting is important too, so that way you're not constantly giving yourself a headache. The actual work task itself might need modification, or there might need to be patient education around it, or there might need to be elements while a patient is in recovery after an injury that have to do with kind of an accommodation or something of that nature. For example, there might need to be a reduction in excessive repetitive motions. So somebody has to use a wrench in their line of work constantly because they're on an assembly line. There might need to be a time limit on that. So for example, if they have to use that wrench normally before their injury 2 hours a day, it might have to drop down to 1 hour a day or 2 30-minute blocks a day. That's a very common accommodation I've had to write language for patients as they slowly return to work after recovery from a surgery or something like that. There may need to be discussion about different equipment so that they don't have to express as much force through their hands or legs in order to perform their work tasks. They may need to take breaks from having their hands on an object, gripping and things like that, or they may need to take breaks from maintaining a static posture that's leading to fatigue, particularly if they have to bend over and they've had an injury that affected their back or their legs. They might also need to minimize pressure points, especially if they have to lean over something and their hip is bumped into something. And then they might also need to make sure if they're in one position for a really long time that they come out of it. Some of you may notice that I have a tendency to kind of like move out of a position when I'm talking. Off and on, that's just me keeping everything limber. I plan to teach for as long as I'm able to, and I want to make sure that I'm not just standing all the time when I'm talking to y'all during lecture. So here's a nice image of a technically ideal work setup, noting that the hands are down low where the keyboard is, so that the elbows and shoulders are not at an angle that causes a lot of distress. Even though this was pulled pretty recently, the computer for some reason is still a giant monitor. They haven't updated that, and there's still for some reason a physical telephone. But you get the idea, this general idea that things need to be at good levels. So it's less that you need to have the specific equipment, and it's more just that you want the wrists free, the lower back actually supported, thighs horizontal, feet flat on the floor, concepts like that. This gets really interesting, though, when we're talking about somebody who has to do work from a wheelchair. There's a lot to consider there. This is purple hexagon, but there's a lot to consider when you have somebody who needs to operate from a different height. So I just have this here for your reference if you have somebody who is in the work environment but works from a wheelchair. Okay, let's go ahead and transition over to overhead athletes. Okay, so now we're going to talk about the overhead athlete. Overhead throwing, the act of pitching, is one of the most studied human movements. It offers this amazing window into the meeting of motor control and orthopedics, because throwing mechanics offers us the application of many motor control concepts and interestingly overlaps with ergonomics. Why? Because it has a lot to do with volume, fatigue, injuries, sequencing, force couples, environment, attractor states, specificity, all kinds of things. Motor control exists in ortho. There is a clinical practice guideline for adhesive capsulitis. And note that in adhesive capsulitis, there is language around neuromuscular re-education that has to do with scapulohumeral rhythm and the capacity to perform a normal motion that has to do with control. So this is purple hexagon, but it's just me showing you that neuro is always lurking even in ortho. And it gets to my old joke that if ortho goes on long enough, it becomes neuro. Although the truth is that if neuro goes on long enough, it becomes ortho. And then if anything goes on long enough, it all becomes cardiopulmonary because everyone deconditions. Okay, so here we have the phases of throwing. So this is for an overhead throw. These motions are achieved through motor control because they have to do so much with sequencing. There's so many elements in learning. It's not particularly natural to just throw like this right off the bat. There's so much around learning to be able to do this correctly. So now let's start to think about how we assess someone and their ability to perform this. So how do we assess motor control of the scapula? Well, we have this really cool test that we can do that has to do with the upper extremity Y balance in quadruped. So we'll set this up in class and we'll do visual movement analysis, which is an outcome measure. And you can take a look at the person's aim, their speed, the stability of the scapula, and your ortho faculty who will be present can jump in and help y'all work on assessing. Can we tell if a person has good motor control of the scapula? So many different musculoskeletal considerations when we're talking about, is somebody ready for throwing? So this is a previous slide that you saw, and the same principles from gait and posture actually apply here. You really have to know normal biomechanics to assess motor control of specific joints, especially ones like the shoulder. And range of motion is why you still want to consider these things. Because when we're thinking about scapular dyskinesias, we're looking at stability and rhythms. And a lot of that is achieved via, is something moving enough and is there enough strength? So let's just kind of look at what's supposed to happen. The glenohumeral joint is a convex head of the humerus and a shallow concave glenoid fossa of the scapula. It's ever so shallow. So how do we get stability? Well, thankfully, you have muscles of the rotator cuff that have to work very dynamically. In order to work properly, they really need neuro to be on board, and that's a healthy somatosensory system to work. You have to kind of know where everything is in space. Passively, you have a lot of tension. And the tension is from the capsule, ligaments, labrum, tendons, and the mechanical support of proper posture and alignment. Is everything sitting where it's supposed to in terms of when you're in an upright seated position or standing position? All of that together is via alignment and tone, and it kind of creates this negative intracapsular pressure that keeps the humerus up against the fossa of the scapula. So these, honestly, the alignment of the glenohumeral joint is kind of the manifestation of postural control elements. It's tone at rest, it's muscle strength and power, alignment, and then whatever range of motion is available. So with all of that alignment in place, then you can actually look at, is it moving properly once things get more dynamic? And that is scapulohumeral rhythm. So this fancy phrase is a way of describing the shoulder synergies, because remember, this is actually more than one joint operating. So the synergy here is a predictable muscle activation pattern. So these have to happen in certain orders and sequences at the same time, and they also describe certain ratios of motion. So for every 3 degrees of abduction that you see, when somebody abducts their shoulder, what you're really seeing is 2 degrees of glenohumeral abduction and 1 degree of scapulothoracic upward rotation. Because remember that we call the shoulder is really basically 2 joints, and then we don't even really want to get into, all of the clavicle and whatnot. There's a lot going on there too. So 180 degrees of abduction is really 120 glenohumeral and 60 scapulothoracic upward. So real life and literature varies. I'm going to defer to the ortho faculty, but this 2-to-1 ratio is decently correct even in real life. So when we get to class, we'll go home and let the ortho faculty tell us about what they see in real life across different folks, and particularly different athletes and different forms of industrial athlete. So this now gets us to this next idea, that what you have here is essentially a force couple. So in order to perform overhead motion, you have forces that are equal in magnitude, parallel, and opposite in direction. They work together to achieve specific angles of force. So you have the serratus anterior and the lower trap that have to posteriorly tilt the scapula, the serratus anterior and the middle trap to externally rotate the scapula. They have to work together based on timing, and the lower trap has to get in their later phases. All of this to permit all of that rotation and everything to allow the scap to rotate up so that it can be ready to orient the fossa so that it's okay for the humerus to tip upward, okay? And again, don't forget neuromuscular considerations, okay? So this is a repeat slide, but it's just to give you the sense that all of these sequencing problems, these delayed activations, and these problems modifying apply as well. You don't have to, this is the same slide as you've seen earlier when we were talking about normal posture and abnormal posture. It's just hitting you again. That's all timing, okay? And overhead reach is the result of all of these synergies, okay? So two motions are coupled again, scapular elevation and scapular upward rotation. That's why this is so incredibly complex. That scapular rotation is really complicated, and that's why I've purple hexagon to this one, because it's so much. In essence, what you have is the glenoid fossa coming up and going anterolateral, which is kind of strange to really think about. And what it does is it actually preserves the length-tension relationship between the abductors of the glenohumeral joint, which is really cool. So that's the middle dot and supraspinatus. This keeps the subacromial space from shrinking too much. So that's the space just underneath the acromion and the top of the humeral head. If you get too much squishy squish in that area, that's compression, and that's bad, okay? We do not want that compressed. If that happens, that's when our athletes have to come see us. So, has anybody had a little bit of that going on? Feel free to raise your hand if you can. But basically, scapular rotation has to happen or overhead reach really won't occur. And that's partially a function of keeping the subacromial space from shrinking. So I will defer to ortho faculty, and they can use the skeletons to help walk us through a little bit more of that if you want to try to visualize it even better. But this is purple hexagon because this gets really niche, and it'll get easier your second year. I know you've already gone over this in the fall, but I wanted to hit it again so you can imagine really what's going on. Let's think about application, because that's really what today is about. I know that was a biomechanics thing from the fall, but I wanted to refresh you so that you feel more grounded in what we're doing today. Ultimately, we really want to think about how a person operates for throwing, and I just wanted to get that a little bit more for how we live. When we're thinking about overhead reach, yes, it's magnificent for throwing, but also it's important when we're thinking about how we do our ADLs. You really need to be able to reach overhead in order to function in the world. It's important. Look at all these different tasks that you need to be able to do that involve overhead reach. For a typical overhead reach achievement, you need at least 130 degrees of shoulder flexion and abduction. What I usually hear my OT friends make is 140, but 130 is what we're going with for the test. So 130 is your number, flexion, abduction. So if that's a goal you want to hit with your patients, just to function, okay? That doesn't mean that's where you stop. That doesn't mean that's what your athletes are happy with. That's just where you can actually, put on your shirt if that's the way you want to don off your shirt, or put things away in an overhead compartment. Okay, so if something isn't going right, which you will typically see, and this is where we're going to do an activity in class, what you will see is a scapular dyskinesia. This is any abnormal position or movement of the scapula. The two most common findings we will see are reduced upward rotation when we ask someone to flex or abduct. We also tend to see excessive downward rotation, internal rotation, anterior tilt, or elevation. We also sometimes see winging. So you can see this person on the bottom here at rest, and then with active forward flexion on the bottom right, and see that winging. See that there? This individual here, wow, that is really, really, really off. So abnormal position, hardcore, and we'll get into that quite a bit. All right, I'm going to save these for when we get to class because they're a lot more fun in real time, and that lets our ortho faculty jump in a little bit more. All right, let's go ahead and pause here, and then we'll kick over to pitching.